life jacket. Wear it, put it on.
যে রোহিঙ্গা আছে মায়ানমার রোহিঙ্গাদের ক্ষেত্রে আমরা বেশি কেস পাচ্ছি যে 3 জন 5 জন বা 8 জন দ্বারা রেপ হয়েছে এরকমও পাচ্ছি।
I thank God, I'm so much very happy that I gave birth in this very place.
وأنا نفسيتي كانت تعبانة، أنا بظهر لأولادي إنه قوية بس أنا بالداخل تعبانة.
Good evening and welcome to tonight's webinar from Médecins, Frontières Australia. The theme for the webinar tonight is Women and Girls on the Move. My name is Margaret Bell. I am one of the medical advisors here in the Sydney office, predominantly focusing on sexual violence. I'd like to introduce you to my two friends, colleagues sitting here beside me. First of all, to my left is Lara Latina. Lara is a midwife who is also one of our women's health advisors based here in the Sydney office and has had many years of experience with Médecins Sans Frontières in various contexts. Welcome, Lara.
Hi.
And sitting beside Laura is Devash Nadu. Devash is a clinical psychologist. Devash has worked in 2 projects for MSF in Iraq and in Palestine, so comes with a vast amount of experience also. So welcome, ladies.
Thank you.
And welcome to you. So as you could see by our short introductory video, the theme for International Women's Day was Women on the Move. Now, IWD was on March the 8th, and we chose that topic for IWG and for tonight's webinar because there are more people on the move now than any other time in history. And we wanted to draw attention to the specific health challenges for women and girls who are displaced. In 2016, the largest ever number of people were forcibly displaced and the largest ever number of women and girls. 32 million, in fact, were displaced internally in their home countries or across borders. Everyone's journey is different. Not everyone's journey is the same. Some people have a long journey, some people's journey is very short. And unfortunately, as we know in the context of we've worked, many people's journey is still ongoing. There are many health issues faced for all people who are displaced. Some of those they carry with them from their place of origin. Some of those are from the experiences that they have found along their journey. And other things are because of what happens to them when they arrive at their destination. But tonight our focus is on women and girls. And we know that there are specific challenges that they face during times of displacement that will have significant and often severe health consequences. These health issues are often common for women and girls all over the world and are often related to their sexual and reproductive health. But we know during times of displacement that these health issues become very exacerbated. Women and girls are also at heightened risk of sexual violence, and like anybody who's displaced, their mental health suffers. So for the next 20 minutes or so, we are going to be discussing some of the specific issues for women and girls in relation to their health. We're going to be looking at what makes them vulnerable and what is MSF doing to support women and girls that face these challenges. So before actually we move to Lara, I'd like to say that please, we welcome questions throughout the webinar. So please post those as you wish. We will try to answer most of them, or some of them at least, but if we don't get to them tonight, we will do our very best to answer them over the next few days. So Lara, we might just start by asking you some questions about the specific challenges that women and girls face because they are actually female. What have you seen in your experience?
Yes, so pregnancy is the first one and a big challenge. 42% of pregnant women might have a complication, and 15% of these women in any population can have a life-threatening complication. So, and this complication can happen during antenatal periods, during childbirth, and afterwards. But because they are this displacement, then the main problem is they don't have access to health care facilities, and they don't have access to a skilled birth attendant. So if they have a complication or if they have a problem in pregnancy, they don't know where to go, and they can't access. So if they bleed or they have a hypertension problem, high blood pressure problem, they can't get medication, they can't get treatment, they can't be followed up, and they can't access to a professional. And this is really can have impacts on their health, and they can lead to death.
So when you say they don't have access, it's because their services just don't exist often in the journey of displacement.
Yeah, doesn't exist, it's not available, or if they have some drugs, for example, they might finish it. So, and women still get pregnant, and they're still pregnant on the move. So
yes, exactly. Yeah.
This is might be a problem.
Yeah. So imagine if you're, crossing the Nuba Mountains, from South Sudan into Tanzania, then, and you go into labour, then that's going to be a massive problem. If you have one of those life-threatening complications and there is no one to assist you in that safe delivery.
You might also die for that. If you bleed to death and nobody can care, then you might even die. And also, and this complication related also for the baby, to the newborn. If there is any complication or anything that they need and they don't have access, then they might die as well.
So apart from pregnancy, what other are some of the issues that might affect women or certainly affect their health?
So another problem or challenge might be lack of contraceptive or lack of access to contraceptive or family planning. For example, teenagers or girls that they don't have access to it, they might get pregnant, they might have unwanted pregnancy, and this might lead to a greater risk for that, for their pregnancy and for their childbirth. So lack of access of family planning contraceptive might lead to unwanted pregnancy, then can cause other problems, issues.
And I suppose some women may not have even had access to contraception at their place of origin. If that's what they wanted, they still may not have been able to access that. But then if they did, possibly the contraception options they were using either ran out or they just couldn't take them with them on their journey.
It might happen.
So what do so if you do experience an unwanted pregnancy, what can people do in times of displacement?
If you experience unwanted pregnancy, you are on the move and you don't have access to safe abortion care, then it might happen that women can seek unsafe abortion, and unsafe abortion can lead to death or can lead to really bad consequences for a woman's health. So this is another problem of lack of accessing care. So if they don't access, then they might have another complication. If they do access, then they might have the right treatment for them.
Wow. So, and I mean, Devesh, in your experience, you've probably worked with women that have a pregnancy that they maybe wish they didn't have, or in this situation of displacement, it's just not the ideal place to actually have a baby.
Absolutely. I think in addition to the physical health risks, there are significant mental health struggles experienced by women, displaced women, in terms of unwanted pregnancies, and this ties in with their absence of control or choice or rights around the issue, and it might lead to psychological distress in terms of feelings of shame or guilt, and particularly if they have cultural beliefs or values surrounded around that, it may lead to significant antenatal or postnatal depression. And in contexts where sort of emotional disturbance is not well tolerated or accepted, this might present more somatically or in physical symptoms, but we'll talk a little bit more to that later in the webinar.
Because I think, a point to make, I suppose, is on top of being pregnant, whether you wish to or not, you're also trying to deal with the day-to-day issues around survival when you are displaced. So all that together
Yeah.
can have an amazing impact.
You might have other children as well to care. So
Exactly. So
Yeah.
precisely. I mean, something that comes to mind, I guess, when we talk about, and obviously it is my specialty, but when we talk about unwanted pregnancy, one of the complications, I guess a reason why some women do unfortunately become pregnant is because of the high rate of sexual violence. We know that violence occurs all around the world, and we know that 1 in 3 women will experience some form of violence in their lifetime. But we also know that sexual violence increases dramatically during times of conflict and displacement. Women are often vulnerable, often families are separated, often forced separation. So women become the head of the household, and it puts them more at risk when there is they don't have a male for protection. I mean, that violence can occur anywhere along the journey. It can occur at their place of origin, it can occur on their journey, it can occur when they arrive in the settlement. And unfortunately, sexual violence, has been known to be used as a strategy of war, but just exploitation of women's vulnerability, bartering, sex for basic survival needs like food and shelter and water, which of course women want for their families. So they're really at risk. I think also the other group that we forget about, well, not forget about, but are girls, adolescent girls, and you referred to them, Lara, in relation to pregnancy and how more at risk they are of health consequences regarding sexual violence. That is also an issue. And I know, Davesh, you were talking about there's some stigma around, particularly around single women and pregnancy.
In my experience, I think young unaccompanied girls are at particular risk. Often they're targeted at night, or when, as you say, they're accessing basic needs like using the latrines or going into seek food parcels and so forth. And their exposure to gender-based sexual violence is often only disclosed when they might come to a clinic and speak of an unwanted pregnancy, for example. And at this stage, they might become quite ostracized by their community. And while suicide is not a terminology that's widely utilized in a lot of the contexts I've worked in, they certainly, in order to avoid shaming their family or greater family systems, these girls will execute honor killings.
Oh goodness, apart from everything else, it's just another thing to manage. And so for an organisation like Médecins Sans Frontières, we do provide medical care and psychological support for victims of sexual violence. We did have a webinar relating to sexual violence and the issues. We covered a lot of the issues around sexual violence. That was in July 2017, so you're very welcome to go to, I think the address is coming up on the website now if you'd like to know more about sexual violence. So we might just now we've talked about the issues for women in pregnancy, we've talked about lack of access to contraception, some sexual violence. So what does MSF do to support women? What can we provide for them?
Well, the activities depend on the context where we are. So when we have a displacement situation, there is a team who goes there and assess first the context so that we can plan the activities according to the needs. I can give you 2 examples. The first one is about Bangladesh with the Rohingyas refugees. We do have a consultation room where women can go and solve any problems related to pregnancy, related to contraception. And the second activity that we have is about a maternity hospital, a small one, where women can access 24/7. So we also kind of link with other actors. For example, in the camp, there are no services 24/7. That's why MSF decided to open a maternity 24/7. The second example is about the Aquarius ship on the Mediterranean, where we do have a dedicated midwife who goes to each woman in the ship and ask them about any problems they have. They run pregnancy tests, they run any consultation they need, they check pregnancy, they assist to birth if they give birth on the ship. and they spend the few days with the midwife. So it really depends on the context. We might have a mobile clinic, or but we try to provide a full comprehensive care for women. So if we are not able to provide, then we refer to other organizations or other hospitals.
So, for example, if we, obviously some pregnant women will require a cesarean section. So if MSF can't provide that, then we would refer to an organisation.
Yeah, we can refer to a hospital. This happened in Bangladesh. We don't provide C-section, for example, surgical care, or for high complication or life-threatening complication. In that case, we refer to another hospital that has the capacity.
I mean, I think the point you make is that the assessment is about providing what's appropriate for that that population in that particular context. I know I visited the project in Uganda, in a place called Yumbi. It's managed as a camp for the South Sudanese refugees that have come across the border over the last 12 months. And so they had a sexual violence clinic in the reception centre where people move in when they first come into the camp. And then we also had one in the hospital that was set up, so we were sort of able to do, and then in an outpatient setting, so we're able to do a bit of both. Yeah. So I think just before we focus on the mental health issues for women, I think it's a good point to make now that obviously we need people to work in our clinics. So we do use a lot of national staff, don't we, MSF, in our programs. Can you talk about the Bangladesh situation?
Yeah, so the national staff run the activities, the main activities, and we do have international staff, in that case midwife or doctor, who support the national staff. So it really depends on the context, because in Bangladesh they are trained midwives, and in other contexts like in South Sudan, midwifery qualification is new. So we provide extended training, or we do superclinical supervision. So again, it depends on the context, but the national staff usually run our activities, and the international staff are there to support them.
But I would imagine that, in many places, the national staff probably are people that have been affected by either that displacement or by that conflict. So that must be challenging for them. And how can we do we support them in some way, Javesh, in your experience?
Marge, we do indeed. I think national staff members often have displaced backgrounds or experiences and exposure to trauma and violence. And I think it's an integral role of MSF to provide debriefing. It's essential for us to provide debriefing, particularly based on that level of experience that they may be lacking at that stage in certain projects, to ensure that they're not re-triggered and that they're not experiencing any secondary traumatization. And it's one of the key and pivotal roles of the international mental health staff to provide debriefing, individual and or group-based counselling support for our national staff members.
I've just known in my brief experience that, I had a few years ago that was a big challenge, that in one of our sexual violence project that was bringing up many of the issues for the staff themselves. So we might now move into, actually, I think that's a good segue into focusing on some of the mental health needs for women and girls who are displaced. Can you just maybe give us give us not a snapshot, but give us an idea of what are some of those issues, some of the stresses that they face?
I think when we're trying to consider the struggles, mental health struggles for women and young girls, we need to consider it in a three-pronged approach with three phases in terms of their pre-flight, their flight, and their settlement processes. And to remember in that pre-flight that the decision to leave a place of origin is often not voluntary, and that there is a lot of loss that goes along with leaving a community, a place of origin, a sense of identity. And in that flight phase, there is the risk of harm, both physical and emotional trauma that is experienced by women. And then settlement often is, it's followed on in different places and often in refugee settings. So while all of these phases have survival as a mechanism, the trauma of the displacement is often placed aside in order to just cope. And
Yes.
in terms of adjustment, they have to negotiate so many different things in terms of cultural practices, language differences, dialect differences, loss of status in terms of their employment or what their qualification might have been held in their country of origin versus where they've been settled, loss of finance and lifestyle. And they have to accept all of this in order to assimilate into these new contexts. One of the points I think that has been highlighted for me is the impact of forced gender separation. And I think I noticed in Iraq that was done for security purposes, and in Palestine based on the ongoing conflict and restriction of movement. And what this has created is single-parented, female-headed households. And this has been quite a significant adjustment for a lot of women who may not have, in their families of origin, been in charge of finances or, for example, disciplining of the children. And this puts these women at risk of putting the family's needs in a primary position and not really addressing their own emotional mental well-being needs. So this increases their propensity or predisposition to depression, anxiety, or trauma-related symptoms. Yeah.
I think a good point you make is, they're dealing with many things at any one time. And I think, when we look at the health issues that they're managing, they don't usually manage one single health issue at any particular time. It's a it's multifactorial.
It absolutely is.
Yeah, not to mention the gender issues that you talk about and their new roles, and then just being a single parent trying to look after your family.
And in terms of trauma, is also multifactorial because most people in their life event may experience one traumatic event, but for a lot of these women and young girls, there are multiple traumas that they're experiencing.
Which often can be ongoing.
Yeah.
Eh? So, Lara, given what Javesh has just talked about, pregnant women coming to birth, they would come with all that, wouldn't they?
Yeah.
So you must see some really vulnerable women in maternity.
Especially, in the delivery room, during childbirth, some women might come alone, and childbirth is one of the most vulnerable time for a woman, and coming alone without support. But also soon after birth with a baby, I'm thinking about teenagers or girls with a baby alone, the family is away. So I think this is really an issue, but they can lead to postnatal depression. So and they need a lot of support.
So how do we provide that support, Javesh, from your experience? How do we provide them with this mental health care?
I'd like to just echo something that Lara pointed out earlier, that care is very context dependent. And in my experience, for example, in Palestine, in Nablus, we have a very established project which has been delivering mental health care for over a decade. And community awareness is what has created an amazing foundation for this project. But in Gaza, for example, there is a lot more reticence or distrust around mental health care or talking therapy, and we're often seen as spies. And I think one of our roles is to demystify what mental health delivery is and take away that sense that it's this hidden, invisible problem, And we do this really well in Iraq. I saw this happening really well at border crossings, where we delivered a lot of psychological first aid, where we were able to provide people with that opportunity for a release and relief, and humanize the process, and to allow their thoughts and their emotions to just be accepted, and to understand that those emotional responses do not need to be pathologized, and that what they're experiencing emotionally is quite normal, considering the level of severity of trauma that they have been exposed to.
So psychological first aid is where you just give somebody a chance to talk and validate their situation.
Yes, and it's often that first response. And what we did in Iraq is that we established a mental health clinic alongside the primary healthcare clinic, sort of on an MSF little premises, and we we were able to work incredibly collaboratively as a team. And a lot of our referral sources actually came from identifying women who were presenting for those somatic responses, those physical responses we spoke of earlier, in terms of diabetes or hypertension, but looking at their stress levels or their lifestyle choices and what was actually what could be managed from a more holistic perspective and managed from a psychological and emotional perspective in order to combat those things.
I know in the Aquarius, you mentioned the Aquarius, where people are about 3 days out there on the Mediterranean and providing midwifery care. But I know also they do provide the psychological first aid, where they just try to start the conversation with people, so it starts, you know, their journey to recovery, I guess.
Yeah. Absolutely.
I certainly saw that in Yumbi recently when I was visiting the project that's in northern Uganda for the South Sudanese refugees, where we had a mental health component, and the doctors from the outpatient department would refer to that clinic originally, but once it became known that community awareness by word of mouth, then people would self-refer, which was great.
Absolutely.
Yeah. Now, I'm just wondering if we have any questions. We do. So we've got a question from Paula. How are sexual assault patients supported, cared for, treated? Sexual contacts or assailants followed, especially with a patient on the move. So how are sexual assault patients supported? So as a medical organisation, our primary focus is on the medical care, which does include psychological support. So we have a very clear medical protocol, which is based on prevention of sexual transmitted infections, which includes HIV/AIDS and hepatitis B. We prevent pregnancy. We provide tetanus vaccination. Depending on the length of time from the actual sexual assault to the time they present, depends on what medical treatment we can give them. We then do provide them with mental health support. I think you've mentioned that, Devash, in your comments. I don't know if you want to make any more comment about that.
It was a more shorter term based intervention, so we're looking at a trauma-based CBT, for example, and this is just based on the fact that people, as the question says, might quite shortly thereafter be on the move. So it is more of a containment and ensuring that their sense of safety is felt before embarking on processing anything more that could be re-traumatizing or not closed properly before they move on to the next phase. So it's a lot of stabilization in order to allow them to continue to cope optimally within the context at the time.
Because I think that's the thing, isn't it, that ideally for a person who's a victim of sexual assault, we would like them to come back and we would like to do follow-up care for as long as they need, but the reality is that we may only see them once because of either by their choice or because of that displacement. The question there, Paula, about sexual context or assailant followed. So our job is to focus on the patient or the woman or the victim, the child, man, woman that comes to our clinic. We don't do contact tracing of the assailant. We don't do contact tracing for that victim's sexual contacts, if that's what you're referring to. We provide confidential care, and that's one of the successes, I think, of providing any medical care, but certainly something mental health or sexual violence care, that there is such a fear of retribution and much other stigma attached to it that it is entirely confidential. So I think that's what your question is relating to, but please feel free, if we haven't answered adequately, we can follow up in the next few days. I think we have time for another question. The second one, in MSF experience, just trying to read, sorry. In MSF's experience, what is the reaction or behaviour of men in relation to family planning and birth control? That's a great question.
Yeah.
Over to you, Lara.
So it really depends, I would say, on the project, where MSF is. In some projects, women come with men to ask contraception, and we talk to both of them, and there is a discussion with the professional. And in other contexts, women come alone and ask for it. If I think about displacement women or displacement population, I think most of women would come alone. Sometimes they don't have husbands, and they would come along and choose for themselves. But I would say it really depends on the project where we are. I don't know if you want to add something more.
Yeah, I think cultural relativity is something that we accept and we respect within the context, and often education is important for us, and this is how a big mandate of the projects is to provide education, to create an understanding of why we deliver this service rather than just implementing a westernized approach or what is perceived as a westernized approach within context in which we're trying to deliver the culturally sensitive
and also delivery. This is part of the assessment that we do, try to understand the context, and also if it's appropriate, we do go to a community and we do run a sensitization program. We talk about contraception, the importance of it, the impact that has, the huge great impact that has in women's health, also men and the family. So we try to talk with the community before implementing
which is really important, and I think one of the reasons why the programs are often successful. Well, unfortunately that's all. We only have time for those questions, but as I said, we will do our best to get to the questions that we haven't been able to answer tonight. Before we wrap up, I'd just like to make a comment that we do recognise that there are many men and boys who are displaced, and we recognise that they have some similar health issues as women, some not, obviously. They've suffered physical and mental traumas as well, and we do provide care for them. Tonight, however, our focus was on women and girls, so I hope we've been able to highlight some of the challenges that they face in their journey of displacement and show you some of the support that MSF does provide to them. So, as I mentioned earlier, this was the topic we highlighted on International Women's Day. So if you'd like to go to our website, there's some beautiful stories on the website. I think the address is coming up on the screen any moment now. But if you'd like to go to the website, there were some lovely stories from patients and from our staff that addressed a lot of the issues that we've talked about tonight. So because of that, I would like to actually finish off tonight by showing you a video. This is Salma. Salma is a Syrian refugee who is now living in Jordan, and would like to share her story with you. So thank you so much for participating tonight. We've enjoyed being here.
Thank you.
And we look forward to seeing you at our next webinar. Thank you. Good night.
نفسيتي كانت تعبانة. أنا بظهر لأولادي إنه قوية بس أنا بالداخل تعبانة. مرة يعني امرأة بعمري وبسني أروح عند أخصائي نفسي، فبالأخير شجعت قلت لا بدي أروح أجيب. قلت له أنا ابني كمان صغير وجبته لابني، فأنا أجي أنا وياه. هو طبعا أخصائية نفسية للأطفال وفي أخصائية نفسية مثل ما بقولوا للأمهات. طبعا من جلسة لجلسة لجلسة الحمد لله يعني كانت رح توصل فينا الحالة للاكتئاب، بس الحمد لله قوينا نفسنا، شجعنا. خلص قلت لأولادي خلص بدنا نرضى بالحياة.